Hello, and welcome to yet another episode of the Bombay Orthopedic Society's Video Journal Club. I am Dr. Mishil Parekh, and I am an orthopedic oncosurgeon from Mumbai. Today, the topic that we're going to discuss is primary aneurysmal bone cysts. Is percutaneous sclerosant therapy with polidocanol effective? What is an aneurysmal bone cyst? Well, the WHO defines it as a benign tumor-like lesion that is described as an expanding osteolytic lesion consisting of blood-filled spaces of variable sizes separated by connective tissue septae containing trabeculae or osteoid tissue and osteoclast giant cells. This is a locally aggressive lesion, and 70% of these are primary, whereas 30% of them are secondary. This is the imaging of a calcaneal ABC, where on the X-ray you can see a lytic lesion in the calcaneum with many septae or trabeculae, and on the MRI this corresponds to multiple fluid levels. These fluid levels are the hallmark characteristic of an aneurysmal bone cyst on the MRI, which differentiates it from other lytic lesions like giant cell tumor. Now, why this topic? This is a very common benign lesion seen in general orthopedic practice. This article, as such, clears certain concepts that help in the management of this disease, and it is a comprehensive article with a good follow-up. And what we can say is that the end of this, what we take home could be practice changing in terms of how you manage aneurysmal bone cysts in your practice. This is the abstract where between January 2010 and December 2016, 56 patients who were primarily treated with sclerotherapy for treatment in ABC. The results were very good, where we had 80% healing of ABC by the percutaneous sclerotherapy, and we did not have any complication as such. Now, what is the aim of this article? We aim to analyze the complications, the oncological outcomes, and the functional outcomes of treatment in previously untreated primary ABC by percutaneous sclerosant therapy using polidocanol. The analysis was retrospective, where we had 56 patients who were treated between January 2010 to December 2016. This is the site-wise distribution of the lesions, where tibia had 13 lesions, pelvis had 12, humerus followed by femur, then followed by the smaller bones like the fibula, ulna, the hand, and the clavicle. What is the procedure of doing this percutaneous sclerotherapy? Well, a sterile preparation of the parts. We need a Jamshedi needle that we use for the biopsy of bony lesions, which is introduced percutaneously into the lesion under fluoroscopic guidance, that is under a C-arm in OT. And we need a radio-opaque dye that is injected into these lesions just to check for leakage, because this could have cortical breaks where the dye leaks out into the soft tissues, which is a contraindication for doing a percutaneous sclerotherapy, because the sclerosant may leak into the soft tissues and cause complications. 3% polidocanol was injected into the lesion, a maximum of 4 ml. The backflow of the sclerosant was prevented by locking the needle for 2 minutes and flushing it with normal saline. An additional pressure was kept at the site of the injection for 3 minutes after removal of the needle to prevent the leak into soft tissues, followed by pressure dressing. The end point of treatment was if the symptoms resolved when there was no further growth of the lesion and cortical thickness of the wall of the cyst had started forming. This is what a polidocanol injection looks like. We'll have a short video presentation courtesy Tata Memorial Hospital that shows us how this procedure is done. This is a distal fibula lesion which was treated with a rush nail just to prevent a collapse. This is our armamentarium. You can see in the center is the Jamshedi needle. You have syringes, you have a 11 number knife. This is the dye that is used to inject, and you can see the Polidocanol vials next to it. After a sterile preparation of the parts, when you have visualized the lesion under C-arm, you will anesthetize that part, take a small incision, and then you will insert your J needle. This is how we check the location or the site. We give local anesthesia, then we take a small stab incision. You see the blood coming out because it is a blood-filled cavity. Then you insert your Jamshedi needle into the lesion. As soon as you insert it, you feel a give way. When it enters the lesion, you remove the stillet and you see there is immediate backflow of blood. That is the pressure in the cyst, the blood just flows out of the needle top. Once you are in the lesion, you can aspirate blood. The blood keeps coming freely as if you're losing blood from a primary vessel injury. But this is actually a third space loss from the lesion, and you have to then use your needle to break the loculi inside, the trabeculae, and make the cyst a complete connected cyst rather than being multiple cystic lesions. What happens then is that you can aspirate all the blood that is in the cystic cavity. Then you inject the dye to check for any leakage. You see the dye is well restricted within the walls of the lesion. It is an expanded lesion, so you can see the dye filling up the expanded part. Then you aspirate more blood that you have broken the loculi as much as blood is possible. You feel a resistance, when you're aspirating, that now all the blood has come out and there is no more blood that is coming out as freely as it was. As such, the walls are going to keep bleeding, so you can aspirate more and more blood, but you have to stop at one point where you feel that now most of the cavity or the blood filled in the cavity has been aspirated. You then again break more loculi and check whether you can still aspirate more blood. Now this also scrapes the walls of the cyst, which helps in healing. This is the Polidocanol that is injected into the lesion, and we go slow because it is sometimes painful because a lot of fluid is getting pushed into the lesion. Once this Polidocanol is pushed inside, we wait in the same position for some time. We wriggle the needle to make sure that the Polidocanol spreads along the lesion. We hold this position for some time after all the Polidocanol is gone inside to make sure that nothing leaks out immediately because of the back pressure. As soon as we remove the needle, we then give a pressure for a couple of minutes, and then we take a small suture and give another pressure dressing, which is kept for 3 days. Now, this is an example of an ABC of the proximal tibia, which on serial sclerotherapy has resolved over a period of time. And this is one more of the pelvis, which has again been injected twice, and it has resolved at 2 months, 4 months time actually. And this is how it looks. So a morbid surgery in the pelvis is saved by a percutaneous procedure. So now that we saw how this procedure is done, how do we reassess the success of our procedure? We repeat the X-ray at 8 weeks time and see the sclerosis or the cortical thickening towards the cystic cavity. If there is no response at 12 weeks, we repeat the sclerosant injection. Now, this is in this study, we had 56 patients. One of them was lost to follow, but 24 patients had resolution of their symptoms and the cyst had stopped growing in 24 patients by just one injection. 19 patients needed a second injection. So you can see a total of 43 patients actually resolved on 2 injections. 3 injections were needed in 9 patients, 4 injections in 3 patients, and 1 needed 5 injections. That was a pelvic case actually, a big lesion, and we couldn't administer more Polidocanol in one go, so it needed multiple injections of the sclerosant, but it eventually healed. The results. You can see this is one of the proximal humerus lesion in a small child, which presented to us. We have given him uh, 2 injections of Polidocanol over 12 weeks time, and at the end he resolved. Once we started seeing resolution, we just got one check X-ray done at 6 months, which showed that it had resolved even further and the remodeling had happened and it had become a normal looking bone, at least from the outside. This is a pelvic ABC. You can see on the X-ray, you can see fluid levels on the MRI. This is the supraacetabular lesion, and this was biopsied, confirmed to be an aneurysmal bone cyst. No pathology there. Then we had injections. Now this required 3 injections, and at the end of 3 injections, you can see the sclerosis has happened, and the patient has good range of motion as well as no symptoms. This is 18-month follow-up X-ray that we have for this patient. Similarly, one proximal fibula lesion, you can see the X-ray at presentation, a lytic lesion, thinned out cortex. We biopsied it, confirmed it to be an ABC. We gave him 1 injection, and at the end of 6 months, you can see how well it has healed up. And after 20 months, again, this was a child, so growing skeleton remodeling had happened. And after 20 months, you can see it has thinned out as well with growth, and the patient is absolutely asymptomatic, and even cosmetically there is no such swelling. In this study, in our results, when we had 65 patients in that time frame with primary ABC, 9 of them were not treated with sclerotherapy alone. 2 of them, which were pelvic ABCs, were treated with sclerotherapy and angioembolization. 7 of them required surgery because they had either presented with a fracture, they underwent resection, or had a curettage in the past. And the 56 patients that we had treated with sclerotherapy, like I told you, 1 was lost to follow-up. We analyzed 55 of these patients, and you can see 46 of these patients healed, and 9 of them progressed. 2 of them underwent an embolization, which then settled down, and 7 of them required surgery. Out of the 46 patients that healed with percutaneous sclerotherapy, they were disease-free. 42 of them were disease-free at the end of a mean follow-up of 62 months, while our highest follow-up is 111 months. And the 4 that had recurrence, they were around 2 years time frame when they got a recurrence, and they also healed with a repeat injection of sclerotherapy, and 2 of them needed surgery, 2 of them healed. So overall, 44 of these 55 patients that were analyzed actually healed with sclerotherapy alone, and that is a promising result in my point of view, because the advantages that this procedure gives you is that it is a minimal invasive procedure, it is cost effective, it can actually be done on OPD basis with just sedation if needed, if the child is small or if pain is not tolerable. It avoids the surgical morbidity. Imagine a resection or a curettage in a pelvic kind of an ABC. It bleeds a lot, the surgery is long, it is very morbid at the end of the surgery as well. A patient doesn't have very good functional outcomes, and overall you treat the ABC but you don't have a very happy patient as such. And hence this percutaneous sclerotherapy, if it works, it is a benign tumor, you are not messing with the life of the patient here. You can attempt something that is less invasive and give more advantage. It is easy to perform, it is just like doing a genital biopsy, a little bit of extension to it when you put in a dye or you put in a sclerosant, and you break the loculi, you aspirate blood, just a couple of more steps from a routine genital bone biopsy. And complication rates have been low in all publications that we have seen. Luckily in this article we did not have any complication. Now when I talk about complication, what complications are we expecting? When you see leakage of the dye and you do a sclerotherapy, the sclerosant can leak into the soft tissues and cause soft tissue injury. You could have skin necrosis because of the leaking of the sclerosant towards the skin at the end of your procedure. If adequate pressure has not been applied and the back pressure lets some of it leak into the soft tissue, we have seen pulmonary embolism, in literature. So there are some dreaded complications of this procedure. There are some minor complications of this procedure. Luckily, in this article, in this study, we did not have any complications. And good healing rates. If you have 80% of ABCs in the pelvis or in the limbs that heal by a percutaneous procedure, even if repeated at 2 months interval, I still feel it is not a bad ratio of healing compared to the disadvantages of a major morbid surgery. So the take home message from this article is that we aimed to optimize the local control while retaining maximum functional outcome and minimizing the morbidity of a major surgery. Percutaneous sclerotherapy has the potential to be considered as a new gold standard of treatment. you know, no more curettage, no more resections, no more surgeries as such for ABCs unless your sclerotherapy fails and you have attempted enough times, and then you have to take a call on surgery. And percutaneous sclerotherapy is a safe, cost effective, minimally invasive, and today's go-to treatment for primary ABCs of the limbs and the pelvis. Thank you.